You are welcome, and I really struggle to believe it's the 30th of September already. And I don't know what it's like where you are, but autumn's definitely arrived here, and cases are increasing, coinciding with autumn and the early start of winter pretty soon. So that's kind of where we're at the moment, but I want to do a brief review of a few countries in the world and some important trends that are going on. And we're going to start off with the most glorious country in the world, as you probably know, is North Korea. Coronavirus under safe and stable control. Excellent, according to the UN ambassador Kim Song. And this, of course, is all thanks to the far-sighted leadership of the government of the Democratic People's Republic of Korea. Notice it's got a D on the front, D for democratic. The anti-epidemic situation in our country is now under safe and stable control due to their glorious leadership. Isn't it? It's just nauseating, isn't it? I've told you this before, but I'll tell you it again. I've worked with people from South Korea when I worked at university for a short time in Cambodia, and a lot of the staff there are from South Korea, and they used to cry over North Korea, literally cry. The idolatry, the repression, the internment camps, the torture facilities. It's just the most wretched country in the world, and nothing's been done about it. So what is going on there in terms of COVID-19? No one really knows. There has been some pretty bad reports though at various stages. So, but no one really knows. I mean, I suppose intelligence agents know, but they can't let us know because that would let people know how they knew. So they can't tell us. But anyway, there's the official line. All under safe control due to the far-sighted leadership of the government. Right, okay, moving on from that before we get too angry. UK. Now, this is the official number of cases yesterday. Highest single figure in any 24-hour period. Now, what does this mean? It means this is the highest number of people that have been tested in a 24-hour period and found to be positive. That's what it means. Back at the peak, we estimated there was about 200,000 new cases per day, based on subsequent serological studies. So it's not the highest number of cases we've ever had in a new day, but it is the highest number of people that have been officially diagnosed in any 24-hour period. And as you can see from the string of numbers there, that the trend is not good. The trend is not good. And the numbers from the COVID symptom tracker app are all in the 19,000s. There's actually a new one. Today's not out yet, so I don't know what today's number is, but I would expect it to be comparable. Unfortunately, with these high numbers, active cases well over 200,000. The official number of deaths has increased by 71. And this is the highest 24-hour figure since July. You don't need me to tell you now that we're going to get more deaths because of the lag effects from the increasing cases. Let's just hope the percentage remains small. Now, moving on to India. Now, there's some real data coming out of India now. So we are starting to know a little bit more. So official cases, official deaths. Okay, fair enough. Are the deaths accurate? I've talked to a few people in India, and the deaths in the rural areas especially are massively under-recorded. So the actual death rate in India is higher than this. How much higher than that would be guessing. We don't know, but they're certainly higher than that because, okay, it's not a scientific study, but I've talked to about 4 or 5 different people in India. Yeah, 3 or 4 different people, probably 4 different people in India, and they tell me the death rate is higher than this, especially in rural areas. Now, this is not necessarily the corruption that's endemic in many parts of India. It is the simple fact that in the countryside records aren't kept. The administration just hasn't reached into poor areas. There's a lot of poor people living in urban and rural areas in India, and very often people don't take too much interest in them, unfortunately. Many noble people do, but many officials don't. So the number's higher than that. Indian Council of Medical Research. has done a survey of over 30,000 households and plus 28,000 individuals. National seroprevalence they estimate at just under, well, a fair bit under 1%, 0.74%. So we've heard stories about very high prevalence of seropositivity in certain areas like New Delhi, Mumbai, for example, a couple of the major metro cities in India. But nationally, it's estimated at 0.74. And now this was a good study. It was taking samples from all over the country, fairly large sample size. Okay, you're extrapolating up to a population of 1.3 billion, but nevertheless, good sample size, 0.74%. Now, if that's true, what this means is that some areas in India have had very high cases of COVID-19. Many areas have had very little exposure to COVID-19. But at 0.74%, this means that India is just at the very, very start of the pandemic. The natural evolution of this condition means it's got a long way to go. Now, I don't believe there will be a natural evolution because I think the vaccines are looking pretty good in India, and more on that later on. But dear me, if this is just a natural epidemic with no scientific intervention, we are just at the very, very start. The very, very start. Less than 1% nationally infected, therefore, we assume with a degree of immunity. But nevertheless, that's incredible. That translates to 60 million people that have been infected. Now, we think about 10% of the population of the United States, maybe 10, 11, 12% of the population of the United States have been infected so far. That equates to about 33 million people. And of course, we thought the United States was at the top. Russia, we don't really know. A few other countries we don't really know. But the United States, I think it's we can certainly say, I feel with some certainty we can say less than 40 million people have been exposed. So this puts India at the very top. More people have been exposed in India than any other country already. 18 to 45-year-olds comprised 43% of the sample, 46 to 60-year-olds 39% of the sample. Now, I know it's completely ludicrous, but based on the population of India, that gives an infection fatality rate of 0.16%. So that is based on this number of deaths. That number of deaths and the population of India is what that is based on. The infection fatality rate so far seems to be 0.16%. Now, yesterday I said 0.03% when I meant 0.3%. Sorry about that. So here I've got the infection fatality rate, and the rate I've calculated is definitely 0.16%. I sometimes misread things, as you've probably noticed. Now, if that's the infection fatality rate, genuinely, if it is, then that's as we know, that's still a very low. It's a very low infection fatality rate. Not many people seem to be dying based on the data we have. So that's encouraging. That the infection fatality rate in the UK seems to be about 0.3 to 0.4%, according to figures from the Centre for Evidence-Based Medicine in Oxford. And I can't remember, there was another figure as well. We did look at this, but that's roughly where we are in the UK. It looks like India's lower. Right, but if we assume that 70% of the population could become infected without intervention, that still means, assuming that figure is correct, nearly 1.5 million people could die. Now, this is not a prediction because the vaccine, I believe, is coming quite soon, as we'll see. I believe this epidemic can be truncated in India. But if it ran its course, even at those low infection fatality rates, because of the large population, there could be a large number of deaths. I'm going to tell you why I don't think that's going to happen, although I'm still concerned about it. Anyway, France, just another review. France now. Again, greatly increasing cases in France, over 8,000 on Tuesday. Deaths starting to increase a bit, hospitalisations increasing a bit, and ITU patients increasing a bit. Now, the deaths will increase, the hospitalisations will increase, the ITU admissions will increase, because we already have the increased number of cases, and the lag effect will unfortunately pretty well guarantee that. Still well within the ability of the French authorities to cope, thankfully, well within. Now, the United States, I want to focus on the increasing cases in young adults in the United States at the moment. Recent increases in COVID-19 cases reported amongst young adults 18 to 22, United States, based on data from the 31st of May to the 5th of September from the Centre for Disease Control. So fairly well collected data. Young adults with COVID-19 can spread infections to their contacts and communities. This is an official declaration from the Centre for Disease Control, not up for debate, just a matter of fact. 2nd of August to 5th of September, weekly cases in 18 to 22 year olds. Nationally 55% increase between the 2nd of August and the 5th of September, so just over a month period. The worst areas were the Northwest, 144%, the Midwest with 123%. And the CDC did stress that the increasing cases are not attributable to increased testing. Now, they did say not entirely attributable to increased testing. So some of the increased cases are increased testing, but even allowing for that, there is a genuine increase in the number of cases in this population demographic in the United States between the 2nd of August and the 5th of September. So 55% increase in that 1 month period. And we'll look at some reasons for that now. Young adults also in college and universities. Most of these, or the majority of these, were young adults related to educational establishments. So these people need to take precautions. Mask wearing, social distancing, hand hygiene, and follow local, state and federal guidelines are necessary. And as you and I know from some of the videos we've seen, this has not always happened by any means. Institutes of higher education should take proactive measures to promote healthy environment. So that's the environment of the institution. Now, to take a specific example, so this is less nebulous. Multiple COVID clusters on a university campus on North Carolina. It's not named in the study, but there you go. If you want to work out which one it is, I'm sure you can. North Carolina University, rapid increase in cases and clusters within 2 weeks of opening. So students return, cases shoot up. I think we said this was going to happen, didn't we? I think this was mentioned, that this was inevitable. In this institution, 3rd to the 25th of August, 670 laboratory cases, 96% were in the student age group demographic. And we were not surprised. It's not good that it's happened, but we predicted exactly this, as did many others. 18 clusters of 5 or more epidemiologically linked cases. So 18 clusters of 5 or more epidemiologically linked, so they can see that these have all been transmitted via this higher education institution. They are epidemiologically linked. Bad in that it means there's been a lot of spread. Good in that it means it's not community transmission. They've been identified. All within a 2-week period. Students gathering and congregate in living settings, so the students are a bit crammed together. Both on and off campus contributed to this. So students living on campus, students living off campus, all contributed to this spread. Right, the consequences of this. Enhanced measures are needed to reduce transmission. Yes, obviously. Reducing on-campus housing density, ensure adherence to masking and other mitigation strategies, increase testing, and discourage students' gatherings all need to be done. Now, I did a report yesterday on Florida, and I've had very mixed reviews on it, but most people are saying, yeah, I think you're probably right on Florida. So just a quick email. I'm a Floridian. I can't begin to describe to you what it feels like to be helpless. I'm a medical professional. I understand what is going to happen, but I cannot seem to convince many of my fellow citizens. We can take all the precautions in the world, but there is nothing we can do on a personal basis to stop the exponential community spread. So many people just want to forget that any of this is happening. They want to go and eat and drink and be merry. I am criticised. I am told that I'm living in fear. It's very difficult. I see my chances of resuming any kind of normal life as being delayed for another year. Isolation has its own difficulties, as so many of us know. Remember, most of the people that live in the state are over 50 years old, and death percentages is probably going to be even higher than you predicted. That is from Jean, who is a Floridian herself, and I can only empathise with that difficulty, Jean. But thank you for sending that in as an illustration. Now, news on the vaccine from India. Interesting. Now, the Pune is a town just outside of Mumbai, well, it's up in the hills. They make a lot of motorbikes there, actually. But anyway, I digress. Serum Institute of India. It's called Serum, but they actually make a lot of vaccines. So it probably used to be Serum, but not so much Serum now. World's largest manufacturer of vaccines. So the world's largest manufacturer of vaccines is in Pune, 1.5 billion vaccines. And these vaccines are internationally used. The standards are remarkably high. They are not all, well, I can't say all, but it's a good pharmaceutical grade production system. We use these internationally. Most of their production goes to the developing world, which is good. And they have got experience in making vaccines for polio, which is a wretched disease, diphtheria, which is horrible, but we very rarely see, tetanus, which we see occasionally, pertussis, Haemophilus, hepatitis, measles, rubella. So they're making a range of vaccines already. In other words, they're a very experienced, capable, technical vaccine manufacturer. And they are currently producing the Oxford AstraZeneca vaccine, which I've just learned is now called Covishield. They've made 2 million doses so far for clinical trials. They're increasing that to 10 million doses. They can bump that up to 100 million doses if they want to, really quite readily. And the stage 3 clinical trials of this are ongoing in Brazil, South Africa. Now, they did stop in the United States because of one person. Well, two people have developed an illness in the UK after taking this vaccine. One turned out to have multiple sclerosis. The second one, we don't know if it's linked or not yet, but the trials did stop in the United States after that. I don't know if they've started again yet. Haven't heard that one, sorry. But they are started again in the UK, Brazil, South Africa. That's true. Now get this. The cost of this is going to be $13. That's $1.13. About 10 English pounds for one dose. Now, if this vaccine works, I suspect it is going to be by far the cheapest in the world. I don't know what the cost of vaccine is going to be from other international manufacturers, but they can make this for $13, 12 euros, about 10 English pounds per dose. That is good news. I imagine some of the pharmaceutical companies might be uncomfortable to read that price. Serum Institute of India started manufacturing they've started making a nasal vaccine as well now. So they've started making it for trials. Now it's completed preclinical studies, that's like animal toxicology and things like that. and it's going to start phase 1 in the UK by the end of 2020. So that will just be one you spray up your nose, which should be great. Now, Brazil, yes. Amazonia, there's been a big resurgence in cases. Brasilia, which is in southern Amazonia, 1.8 million people, restrictions there have started. Now, Manaus in more North Amazonia. Now, this was a bit of a strange case. We have looked at it a few times. They never really imposed full restrictions, just a little bit. And there was a lot of evidence showing that a lot of people were probably had been exposed. But it doesn't seem to be working. So herd immunity at Brazilian's Amazon. So this is the name of the paper here. This is where the paper's published. It's not yet peer reviewed. I must say, this paper's been out now for a while. I wish the peer reviewers would get their act together. You know, people are writing papers really at quite a rapid rate, but the peer review process is really slowing things up. Peer reviewers really need to get their act together on this. Anyway, cases increased quickly during March and April, so we know that. Declined slowly from May to September. And the deaths followed. There was an awful lot of deaths at this time. Antibody tests were showing pretty high levels of people being infected. But people weren't wearing masks. They weren't taking many precautions. Bars and parties were attended. Now, the reason I put this in, and the reason this is concerning, is infections now seem to be increasing there quite dramatically. But if these kind of numbers of people have been infected, most experts are saying herd immunity kicks in at 70%. You would expect some herd immunity effects already to reduce the spread, but it seems to be increasing rapidly. So what does this mean? Does it mean that we need significantly higher numbers than this for herd immunity? It could mean that. Some people have been saying that because the antibodies only last for a few months, the people in Manaus have lost their immunity and they're becoming reinfected. Now, I want to stress, I know of no evidence for that. To demonstrate that, people would have to have been infected with the antigen, been diagnosed, got better, and then reinfected with another genetically identified different antigen, slightly different strain of the virus, or even the same strain of the virus if the body had been shown to eliminate the virus. So my belief is that there's going to be T cell, B cell mediated immunity that's going to be long-lived. So I don't believe these people are getting reinfected. I've still only heard of about half a dozen cases of reinfection around the world that have been documented. So I don't believe it's reinfection that's occurring. Were the antibody studies flawed and the real numbers infected were actually less than that? Do we need a significantly higher number for herd immunity? That's probably the more likely explanation. But the cases there are increasing now. So the dipped way down. We're very optimistic it was a herd immunity effect, but it looks like it's not. And we've also been disappointed by the lack of herd immunity effect in New York and London. But these figures here, 44 to 66%, are much higher, and yet it appears that herd immunity has not been achieved. So the hopes we'd had for some level of protection at herd immunity at levels lower than 70% don't seem to have come to fruition, unfortunately. So that's where we're at with that. But I still don't believe this is caused by reinfection. I believe the people that were immune, have experience, will still be immune. If I find any evidence to show that there's mass reinfections, believe me, I'll be the first to report that, because that would have massive import for everything. That would mean that the disease will probably become endemic. It won't go away. That would mean that we're not going to get herd immunity. It's not going to work. That would mean that the immunity induced by the vaccines would have very short lifespan potentially. But I stress there is no evidence for that I'm aware of at the moment, so I don't think it's the case. But we will be monitoring it carefully. My position is I remain optimistic that this disease will be eradicated in a few seasons, 2, 3, 4 seasons. That's still my expectation. That's what I think is going to happen. Time will tell. I certainly think we're going to get rid of the vast majority of cases with vaccine next year, and I don't think that information is going to significantly alter that expectation at the moment. Netherlands, daily record in cases, despite, I believe, fairly limited testing in the community in the Netherlands. I think the Netherlands philosophy seems to be focusing more on sickness and hospitalizations now. So cases definitely rising in the Netherlands, but probably rising much faster and higher than that number there would indicate. National Institute for Health, the RIVM, the number of cases rose sharply in almost all regions and in all age groups in the Netherlands. So, of course, in South America now, in Brazil, it's that they're heading into spring now, aren't they? So hopefully that's going to help a bit. But given the autumn weather now that we're seeing outside, people are going to start going indoors. Of course, quite a few areas of the UK now, households are not allowed to mix indoors or outdoors as new regulations kick in. But it could be a difficult autumn and winter. We're hoping for the best, but the good news is the infection fatality rates do seem lower than we had feared, but they are not negligible. The risks are not negligible. There are risks and ongoing precautions are certainly needed for the next 6 months at least. Thank you for watching this video as always.